Dr. Aki, do you want me to do a test run real quick to see if you can hear it?
Yep. I know the PowerPoint video might not be the greatest video quality, but still, it play.
Well, the first thing, make it simple.
Yep, it's going.
Good. Okay.
Perfect.
Awesome.
So let's start from the beginning.
All right, Doug. Whenever you want to get going, you can just tell me to go next, and we'll go at your pace. Okay.
Okay, thanks so much for joining me in. My name is Dr. Aki. I'm Cornerstone Community Chiropractic, and today we have awesome doctors helping us out. We have a Dr. Sky. We have a Dr. Sean. So we got the highly paid doctors right here, and we're gonna make the things work for the next 1 hour or so. So let's get going. And before get going, I wanna spit it out for one thing I have been learning these days. Are you guys ready? Are you guys ready to take a note?
Oh yeah.
Ready? Let's go. So the more I practice, more I do a cervical chair, the more I realizing that it is not all about me setting up on the patient. I'm gonna say that one more time. The more I practice, more I do a cervical chair, the more I realizing that it's all about me anymore. It's not all about how I set it up. What I mean by that is we need to change the setup based on what we find from the Gonstead system all the time, every time. So just, I don't know how much, Marcos, we can do an engagement. How many of them are students, and how many of them are, how many of you guys are doctors? Can you guys do a chat, or can you guys do anything to get to know them a little bit?
Yeah, we can have people type in the chat.
Type in the chat. Type in the chat. Student. I'm a student. 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 Student, Dr. Aki. Student. Doctor. Yay. Student. Baby doctors. Student. Doctors. Hi, Dr. Adam. Okay, that's awesome. So I am continue to be student of Gonstead Chiropractic Care as well, right? It's all about continuous learning. Today, what I want to share with you is maybe Dr. Schuyler agree with me. Are you ready, Dr. Schuyler? And put you in the spot. You love making coffee? He love making coffee. It's an espresso. Then I don't know about you guys, but I'm learning about the coffee quite a bit. Look, can you see? We make a espresso. We measure 18 grams of coffee powder. Sometimes it needs to be 19 grams, or sometimes it needs to be 20 grams. Then we grind. Are you with me so far? Maybe I lost probably half of the audience. I know that right now, right? Right? Then depending on the humidity, depending on how fresh the roast of coffee is, the hot water gonna come through from the coffee machine going to be different. Speed going to be different. The dripping down is a little bit different way. It coming maybe too fast or too slow. Then when it's too slow, it might be tasting no right. If too fast, it tastes like brown water. So what I'm saying is this. It's not all about how you make a coffee, right? You understanding the coffee bean well enough and engage with the coffee bean so that we can get the best shot ever to enjoy the nice coffee. Dr. Sean, Dr. Skyler, are you with me so far? Okay, good. So that's the reason why today what I want to teach is a little bit more ingredient for the better, more specific cervical chair. But it's all about the chemistry inside of you, how you set it up, but also chemistry with your patient. So I'm going to go over the two parts. First, maybe 30 to 40 minutes, it's going to be a presentation. Then second 30 minutes or so, second 30 minutes to 20 minutes, we are going to do a demonstration. So let's get going. Marcus, next slide. Okay. So that's what we talk about basic. And I am going to give you about some advanced tip as well. Then demonstration, I want to go over the cases today. Let's move on. Go. Next one. Perfect. And hopefully you guys can see this. And hopefully you can pick up some of the keywords. So I'm going to run the Dr. Gonstead cervical chair video. Marcus, I think you share this video on your Facebook.
Yes.
Then you talk quite a bit about don't do a twisting or scissoring adjustment. I remember that. But just I want to run through one more time. And you might not be able to see perfectly since this is the old video, but I want you to pick up a couple keywords. And I want you to write down even a couple keywords. Okay? So Marcus, can you play? Go.
Yes, sir.
Now the first thing is make it simple when you judge, when you get your patient back.
We lost the audio, Marcus. Can you hear?
Can you hear? Are you good to hearing? Everything's good?
No, I don't hear. It was playing.
It was playing, right?
Yeah, it was playing.
Okay, let's try it again.
Now the first thing is make it simple when you judge, when you get your patient back.
It's not playing the volume.
Is it just stopping kind of halfway through in the
The
beginning?
volume stopped for some reason.
Very necessary. You don't have tips there.
There we
Did
go.
you hear
The first thing is make it.
Is it working or no?
It was working.
It is? Okay.
I think you muted yourself for some reason at the corner.
Okay. So you can hear me right now, right, Doc?
Yeah, I can hear you.
Okay. Let's see if I do it this way.
Now the first thing is make it simplest when you judge, when you get your patient back.
Yeah, around here we lost the
It's not,
volume.
he's not talking right there. I don't know if that's,
He pauses for a sec of talking. How about here? Does
Oh,
it?
okay.
On the left
The
hander, right?
technical- Oh, there we go. Sorry.
Yeah, made this up in the left hander. There. It's very necessary that you use the strap in your cervical adjusting.
Okay, can you pause that?
You
Marcus?
want that grip there. That's the first.
Okay, first, I'm going to go over later on. I want you to write it down. Strap at the corner of patient shoulder. Okay? Then moving on.
Thing that you want to use. Then the next thing is necessary to be sure that you straighten your feet out and toes way up this way. Now now that's good. Now even if they're like this, they can still kick. But this way they can just kick into the floor and it tightens up in the cervical muscles of the spine and makes it hard to adjust. Have
Okay,
it
stop
straight.
that for me. Okay, so what he's going over is the perfect patient placement, PPP, perfect patient placement, palms up, and kick your feet forward, toe pointing to the moon. Okay, then you can play.
Like that. And the mistake that most of you fellows make in setting, I'm going to set the 6 cervical for this doctor here. The most mistake you do, but the thing to do now is keep your hand as straight as you can. Your fingers real
Stop
straight.
that right here. What did you hear? Somebody? Keep your hands straight as much as possible. Okay, moving on, next one. That's another keyword. I want you to write it down.
And see that reinforced with the other fingers.
Reinforce the other finger. I want you to write it down.
There's your 6. Then just drop the head back onto your chest. Also settle.
Okay, stop right here. Okay, I want you to see the 2 fingers supporting patient jaw. Write it down for me. 2 finger supporting patient jaw. Okay, then after that, you can play.
Here, like that, see? Keep your head straight. Don't bring it back too far. Then the next step that you want to do is to turn it to the right, quite far, and then come back to its center. So when you adjust the patient, you've got this lever to go on. Now, if you got it over here too far, it tightens over here. Not too many times, you fellows are turning to the right, and you come back like this here, and then you come way back here like that. See, when you're doing this, it tightens up here. That's way too much. Way too much. I'm going to go over that again now. Here's the right procedure to follow through. And I tip it back just like this here.
Okay, can you stop right there? Okay, can you guys see his pointy finger? Can you see that? So instead of collapsing about the thumb like this, he is really pointy finger. Can you see how pointy it is?
Oh yeah.
Okay, now move on. Pointy finger.
There. Then back into its center. You're not ready for setting. Right there.
Okay, stop right there.
Go back in each other. And then where it is right there. Then you stabilize it over here. And now your thrust should come up this way, see? Just like that. You should have the opening here. Now to get up here, but not move. You got to get the tip of your fingers as far as you can. Just like that. And then you can
back off a little bit.
Just set it up like that, see? That's PL interior. Now you see where my right hand is over here now, see?
One sec, Doc.
You can go back.
Yeah,
Hey, Edgar.
it shut down on me real quick. Sorry. I'll get it back up
Don't worry.
real quick.
I said to my team doctor, I usually use a joke. I'm from Japan, and I am not good at technology. Obviously, I'm infecting you, Marcos.
This has never been this difficult. It's crazy.
Yeah, it's all about me. So it's not all about Marcos. Then Dr. Skyler and Dr. Sean knows exactly what I'm talking about.
Hold on, I'm sorry. Damn thing. Alrighty, third time's a charm. Here we go. Share.
Okay, around here.
Come up this way, see? Just like that. You should have an opening here. Now to get up here, but not move. You got to get the tip of your fingers as far as you can.
Stop right there. Did you hear that?
First thing, and make it simpler stuff.
Yep, that's good. That's good. We just keep it messy. Did you hear the tip of the finger? Did you hear that?
Mhm.
Tip of the finger. Okay. Another thing I want you to write it down was Dr. Gonstead was explaining about the inferior to superior quite a bit. Did you see that elbow was more inferior than the rest, and the thumb is more superior than the rest? So it's all about inferior, then superior. So I want you to see the relationship between the elbow, wrist, and tip of the index finger. Okay, go.
And now, here's the right procedure to follow through. I tip it back just like this here, turn it over here, then back into its center. You're not ready for setting, right there. Now it shouldn't go back any further than what it is right there. Then you stabilize it over here. And now your thrust should come up this way, see?
Do you see that come up there?
Now get up here, come up here. You gotta get the tip of your fingers as far as you can. Just like that. And then you just stabilize it here and then just set it up like that, see? That's PL inferior. Now you see where my right hand is over here now, see? Now, I'm down on 7 here with these two fingers. These two fingers I'm stabilizing number 7. See? These two fingers I'm stabilizing the opposite. See? 6. Yeah, but I'm down on 7 now, so that whole thing is stabilized. So you'll only get one clump there, see? You won't get 3, 4.
Stop right there for me, Marcus.
Out of your color.
Okay, I want you to see the hyper extended stabilization hand. Hyper extended means hyper extended. It's not like a vertical. Hyper extended rest. So I want you to write it down, that keyword. Hyper extended stabilization hand. Okay, let's go next.
Doing, you're up here like this, and you adjust 5, 6 vertical. That's manipulation. That's not a correction. I'm going to go on the other side so that you can see over here. Now I can see here now. Here's the idea. Get your fingers up here.
Straight finger.
Like that.
Pointy thumb.
And bring it over this way.
2 finger.
And come back so you got this leeway. Now these 2 fingers are down there. The other's up in the occiput. Now I got his head up against my chest so that everything is stable. Now see that?
Stop right there for me, Marcus.
Like
what did you hear? His head is going to his chest. His head going to the Dr. Gonstead chest. Did you hear the word chest? Say yes.
Yes.
Did you see that? Chest. So you need a stabilization for a chest. Okay, now keep going.
Now, if I didn't have the strap on there, you have to adjust it twice as hard. It's ready for setting, but it should not come back like this. Most of them you're like this. See, everything is tight over here now. See when you come over like this, you're too far. It tightens up here. So if you just watch that very carefully, you can adjust that with very scientific setting and with less the effort, and you will not disturb the vertebral cuff. When you adjust the cervical vertebra, you want 1 clump. You don't want 3, 4. When you're adjusting 3, 4, you are not making a good setting of the one that you intended to set. But you want to be very careful. Now, when you adjust the axis, then you got to come back just a little bit more this way. See? And then you can come over. That's it. Now we got the axis PL inferior. Now you got to drop it just a little more to set that because the angles of the articulation are a little greater. Again, it's just set up like that. See? And don't come with these quick rabbit punches. See here, this is that you don't want. You run a hole this far, and then just come up in here, and then that speed up there to get all the tension out.
Stop right here for me. Did you hear that? No rapid punches. So I want you to write it down. Rest, rest, rest. No tricep. Punches are coming from tricep. Right? Punch doesn't do anything. Punch does more tricep contraction. So rest, rest, rest. Okay, move on, next one.
You adjust that very scientifically. Now I'm going to get up to the atlas. This holds true in all the cervicals from 7 on up, including axis.
Okay. So let's move on to the right. Okay. So this is something I cannot emphasize enough. I'm going to say this one more time. Do a cervical strap. Practice with cervical strap. Okay. Then I'm going to start to get into the little demonstration. Then also like, the presentation as well. So what I'm going to ask is, Dr. Sky, we're going to flip that, boom. Okay. Then Marcus,
Yes.
you can keep going about the
Okay.
presentation if you want to. Dr. Sean, come on right here. Okay. So I'm going to go one by one. Okay. Can you guys see me, or should I go back and forth between the presentation? What do you think, Marcos?
I'll stop presenting so everyone can pin you, and
Okay.
then they'll see you on a big screen.
Okay. So the strap, cervical strap, please use it. Then this is the reason why. When we see the cervical disc is this much. Okay. When I adjust on patient body move even half inches like this, are you effectively correcting that disc? This size, right? Patient move half inch. Are you effectively correcting about that spinal disc issue? Then everybody said, no, Dr. Aki, right? So please use the cervical strap all the time, every time. Okay. So tip is this. This is something like, not in the chapter, but I really want you to pay attention for right here. So when you do a cervical chair, then strap, patient might be around the curled up right here. So don't just do this. Okay. I want you to watch. This is the science, art, and philosophy. Okay. Have them open the chest first, then corner a little, pull down, then palms up for me, then kick your feet all the way forward. My question to you guys is this. Do you want to do a cervical strap right here? Or do you want to do a cervical strap right here? This open you up right away, immediately. So that is so important. Okay. Opening up, it's already, his disc is opening up. So everything going to be easier to open furthermore. Okay. So that's the first one. The next one, let's go back to the presentation. Can you go back to the presentation maybe a little bit? Maybe
Yes.
not?
Yes.
Okay. Okay, that's a perfect patient position. I already talked about that. Okay, moving on, next one. Okay, so this is just a little bit more advanced information for you for the chair angle. Okay, so in general, we say this, right? I want my patient to sit down as vertical as possible. Definitely. But now, by seeing about many patients, I see so many 20s are walking like this. So what I want you to start to play is the angle of this cervical chair. Try to do as vertical as possible, but don't hesitate to change the cervical chair angle. That's going to help maybe some patient to open up a little bit more. Hyperkyphotic patient, nowadays we see the hyperkyphotic patient in 20s or 30s, right? So don't hesitate to change the chair angle. That's very important. Okay, moving on, next one. Okay, I want you to see this x-ray. Okay, can you see the first one? Straight. Can you see the third one? Third one is already have a pretty decent curvature is going on. But when we see the thoracic, it is really difficult to see the kyphosis as well. So what I want you to see based on this, next slide, can you go to the next slide? And I'm going to advance that right here. Patient jaw location, okay? Can you go to the Marcus next one? Okay, here we go. Dr. Gonstead was doing this. right there, right? Then what I want you to differentiate based on the first picture, second picture, and third picture is this. First picture, you might need a little bit chin up. Can you see that? Chin up. Then when you do that, it's gonna help him to create the lordosis. His tension of the neck going to be less. Okay. On the flip side, if you already have a third picture, already have a decent curvature is going on, when you do a setup, you wanna maybe keep the jaw location as neutral as possible. Then lateral bend. So you wanna play. This is a little bit more advanced skill for you based on the patient lordosis. Either if you have a kyphotic neck, you might need to set up about way more chin up to help them to open up first, then adjust. So that's something you want to think about. Again, life is not all about how well you make a coffee, right? You need to engage with coffee bean, humidity. That's what I'm talking about. Okay, next one, Marcos. Okay, so we already talked about that as well. So it needs to be a straight finger. Then this is the reason why if you curl up too much, distance between the tip of the finger and thumb going to be shorter. If you do this, distance between the tip of the finger and thumb going to be wider. Why it is advantageous? This is the reason why. This going to be the pivot point. Then when you lift, when you use the rest, it's gonna create about the more lever. If it's really close to each other and adjusting like this, it's gonna be a punchy adjustment. Okay, that's the reason why Dr. Gonstead was saying about keep the finger as straight as possible, making the distance and using the tip of your thumb to create this. Okay, Dr. Marcus, next one. Reinforce with other finger. Maybe you remember hearing from the Dr. Gonstead mouth, right? So when it comes to the reinforcing, this is what we are looking for. Okay, so your index finger is going to be more superior. Then this is backed up by the middle finger. Middle finger is slightly more inferior than the index. Then if you want to use the fourth finger, you can back it up. So when you see this, it needs to be a stair stepping. Like that. Okay, then next one. Two finger on the jaw. We already talked about this, right? By having the two finger, Dr. Sky, come closer to the jaw. By having the two finger for the top part of the jaw and bottom part of the jaw, now I got this with my chest, then now I can control wherever the location I can bring him in. Did you see that? He was maneuvering about the nose location quite a bit. So by having the two finger with nice, maybe German jaw help, right? German jaw is a little more sticking out. By the way, not all the patients are German, so it might not work. But what I'm saying is, by using the two finger, you can control: is it tucked in more, or is it let it go a little bit more? If it's let it go too much, certain patient already closing about the facet, and you are not gonna get the good adjustment. But hyperkyphotic patient might help about a little bit jaw up, then lateral bend. Then tip of the finger going to be on the patient jaw. Okay. Next one. Moving on. Are you doing okay, Dr. Chan? Use your chest on square stance. Okay. I'm gonna say this one more time. This is not like this seminar said this or this not seminar said this. This doctor said this. This. Literally, it's in the chart. I know I'm kind of stirring the pot, or maybe make people uncomfortable. It's okay, because Dr. Gonstead said he was using chest, right? Then also, next slide, when you go to the Marcos next slide, you are going to see in the chapter, Dr. Gonstead was square, and Dr. Gonstead was using the chest. As a matter of fact, if you hear the old doctor who was in the Gonstead clinic, Dr. Gonstead always got the spot on the clinic jacket, right? Then why, right? Back in the day, man wear all the oil on the head, right? So if you are catching patient head on your chest, then you are going to have an oil stain. You know what I'm saying? So Dr. Gonstead was using the chest from the video. I'm not making these things up. I'm not stepping on any other toe, but I try to extract about as much information possible from the chapter and from what Dr. Gonstead said. So some said scissor stand, some said this, but try to get square as much as possible.
Dr. Aki, quick question.
Yes.
In the video, Dr. Gonstead was saying he would put his thenar and push the patient's head into his sternum a little bit.
Mm-hmm.
Can you kind of just go over that slightly, or is that by chance just what he means by pushing the thenar into the sternum for the stabilization? Is that kind of what you mean by hyperextend the wrist?
Hyperextend the wrist, but everything work with. Are you ready? So this is a little more Asian fusion, so bear with me. Action and reaction, right? So means if your main goal is P2A for the thrust, what kind of reaction you need to have from the stabilization? Always A to P. So that's what you mean by the Dr. Gonstead was using the chest and the stabilization hand going to be into your chest, so to speak. You know what I mean? Then another thing, if I want to add it on, Marcos, since you are in that journey, again, action and reaction. If you want to get the I2S for the thrust, guess what kind of stabilization you want to get? S2I, right? Then watch. If one action and reaction is not equal, then guess what happened? Or distance or vector going to be off, then like Dr. Gonstead was showing, right? Tilting, then it's going to be a scissoring adjustment. So equal action and reaction, then when it comes together, then there is a perfect harmony or stabilization.
Thank you.
Cool with that? Okay,
yes,
moving
sir.
on. Okay, I don't know if you can play with this or not. Do you think you can play?
Yeah. Let's
okay,
see.
Go.
Another thing. Now, with this right hand, the femur right here on the right side, I got right over his ear, and I'm really pressing his head into my sternum to stabilize. I said, don't turn too much when I give the adjustment. See, now again, I'm going to come over here. I got to allow this much for turn. See? Now you see my femur right here. I'm pressing really backwards into my chest. And then the line of drive has to come up this way now, see? Just like that. But now he can feel, the doctor can feel that, can't you? See? So when that's adjusted, now if you get up here like this here now, like some of you fellows are doing, see how wobbly it is? Then you come in here and then the whole thing gives, and you're just about 3/4 cervicals.
Yep. You don't know. I think you can move on to the next one. But did you understand, guys, that's exactly what I said, right? So stabilization coming to the chest means S2I and A to P. Then instead, he was showing about this is going I to S, right? Then his elbow location is exactly I to S. I to S. Then contact is right here. Then it's going to be I to S. Boom, boom. Okay, moving on, next one. Okay. Thumbs up as high as possible. Did you realize that? I think, in the first video, he talked about this quite a bit. I see oftentimes when I see that Instagram, I know some of you guys might be in, right? When I see the Instagram, this thumb going to be around here. Okay. Then also the thumb is completely collapsed. Can you see that? Instead of collapse, what I want to see is like Dr. Gonstead. See, like he was saying tip of the finger. And when you do that, make a rat hole, Dr. Sky, come from the front, A to P view. There we go. Then can you see it right here? It's way, way bigger than this. Can you see it? It's collapsing. Okay. Now I'm gonna say this after this this slide is this. So keep your thumb as high as possible. Then also almost like a pinchy thumb. I don't want to pinch him, but it almost like I want to see hook it. This. Hook it. Write it down. Hook it. Then when you hook it up, then I'm going to, Marcus, go to the next slide for me. Okay, can you see that? Like way superior, right? Then if thumb is really superior, guess what happened to the tip of the index finger? If thumb is go way superior, this line of drive gonna be automatically I to S. If this thumb is collapsing front, you are not gonna get enough left. Okay, next one. And that's got, go ahead and play. It might be redundant.
Another thing, now with this right hand, the pinna right here on the right side, I got right over his ear, and I'm really pressing his head into my sternum.
Okay, that's good. That's enough. You can skip next one. Okay, so pointy, pinchy thumb. This is the Aki's word. Pointy, pinchy thumb. But I don't want you to pinch the sense that hurting the patient. But what I'm saying is Dr. Sean can feel this as well. Maybe I'm going to start to help him to relax the opposite side of the jaw. Thank you so much for being amazing patient. I hope you are learning something good from here. So much. Okay, opening up right there. Okay. This. So pointy, pinchy thumb. Okay. So go like this. Yes. Boom. Right. Then when I do a lateral flexion, just flexion from here, then hook it right here. When I hook it, instead of collapsing it, hook it, then almost like when you do this a little bit, don't over contract, but when you do this a little bit, then automatically this gonna be I to S. Then it start to pick it up a little bit, then get closer to the thumb, as you can see right here. Don't do pinch too much, but just this, pinchy. Then I set it, I hold it. I hold the spinous process or transverse process or lamina, so it's not gonna go anywhere. Then only things you need to do is this. Again, traveling distance, think about it. If you are so conditioned as the rapid punch, like tricep contraction, ain't gonna work, right? How much you need to travel your desk? Your head gonna fall down, right? You just need this. Your disc space is like this. So lift it and set that joint. Okay. Then pointy, pinchy thumb gonna help you to almost like lock that segment right there. I occasionally change the location of thumb a little bit anterior if I want the more P2A. Maybe I change the pointy, pinchy thumb a little bit more superior if I need a more I2S. So I kind of change the location of the thumb depending on the patient as well. Okay, moving on, next one. Okay, basic number 12. Your 3 vectors come to, oh shoot, did I bring this? Oh my goodness. Oh my goodness. Did I bring this? Did I have it all the time? Did I have it? No, right? I don't have it. Oh man, I'm in the big trouble. I forgot my vector. Oh man. I'm in trouble. I'm so sorry, guys. Make some? Okay. I usually take the vector wherever I go. Okay. Dr. Scott, can you stand up right here in front of me? Okay. Then let's set it up. Okay. So he was saying this, right? After you get this, then lateral flexion from the bend, pinchy, pointy thumb, right? They hook it. Then after that, don't lose it. Boom, hyper thumb, thinner, go into the chest, tuck it in right here, and boom, right there. Okay. What I want you to see is this stabilization angle needs to match up is this. If it doesn't, then guess what happened? Like he was showing this is vector is not matching. Can you see that? Yes. It needs to point it to that location. If you want to be meticulous, he was saying about this index and this middle index finger is supporting the opposite side of the C7. Did you remember? Like you are hearing something like that, right? So any kind of adjustment, you have three vector. One vector is coming from the chest. The other vector is coming from the stabilization, and also contact hand needs to match. If it doesn't match the angle, we're gonna start to do this. Or we're gonna start to do this. That's rotation, right? But vector matching together, that's the time you are creating the true stabilization. Cool. Moving on, next one. Sorry, I'm a little sweaty, Dr. Sean. Did you realize that? I think I went surfing and I forgot the deodorant and I just put the t-shirt on there. Your shoulder is level to your patient's shoulder on floor. This is something Dr. Gonstead didn't talk about this. Marcus, can you go back to the Dr. Gonstead picture from the chapter? Right there. Okay. When we see, this is also, you can see that, right? Stabilization hand and also contact hand is meeting together. Can you guys see that? By seeing about this picture. It is not like, missing each other. It is not twisting each other. It is matching, right? Another thing that I want you to really pay attention is, I want you to watch yourself in front of the mirror when you are practicing the setup. Because when you set up, if you start to lose your, like he was showing about this, right? Can you see my elbow is crooked right here?
Mhm.
When you start to do that again, you are doing a scissoring. But instead, square, coming together, then playing with the jaw and lateral flexion from the segment. Boom. Boom. Then your elbow and your entire shoulder is nice and level. We call what? Some of you guys came to my Dr. Edgar, remember about this? I cannot pronounce this. What's that square? Parallelogram, right?
Yeah,
Am I
that's the
talking
one.
about? Parallelogram. I cannot say that too much L and R going on. But when we see the good adjustment, we see the parallelogram. Dr. Skylar, can you say that for me?
Parallelogram.
Thank you. Can you say that one more time?
Parallelogram.
Okay, thank you. That's the right pronunciation. Okay, moving on to the next one. Okay. Okay, hyper. Okay, here we go. Go back to the hyperextended. So 3 vector mark together. Okay, here we go. Hyperextended stabilization hand. Okay. When you see the Dr. Gonstead chapters picture or in his video, he was really hyperextended. Okay. Then this is the reason why it's important. If it is not hyperextended, you have a so much easier to go this. Again, we are creating scissoring, but as soon as you do a hyperextended wrist, then it's there. It's not gonna move anywhere, right? I want you to do it with me right now in front of your camera. Can you guys do this? Okay, do this one for me, right? Can you see that? Good hyperextended. Then when you get the good hyperextension, then push it against yourself. It's really strong. It really there. It's not gonna go anywhere. Okay. I do an opposite side. It's almost like you are doing a scissoring adjustment. Now you are so vertical right here. Can you see that? Then you push each other. Guess how much bicep you need to hold it? Can you see how difficult for you to hold it right here? When you do a hyperextension, you don't need to use your finger muscle. You don't need to use lots of muscle to stabilize. It's gonna be automatically right there. Boom. Then boom. Cool. So hyper-extended stabilization hand. It's gonna be there. It's not gonna move. It's gonna be stable. Your shoulder weight and elbow weight gonna automatically be here. So you don't need to okay, you need to create the tension. As soon as you create the tension, you can stop. So don't create the even tension. It's there, match the vector, then it's ready to go because it's harmoniously balanced. Cool. Next one. Okay, that's something like you already seen this as well. But medial epicondyl, medial wrist on the tip of the index finger. Okay, then ultimately this tip of the thumb going to be guidance. So when you see this, I want you to really think when you do a rest, boom. This is the pivot point. This is the guidance, and you line them up in the one line. You line them up in the one line, then boom. Line them up on the one line, boom. Then wrist gonna give you the arc. Wrist gonna give you the lift for you. I'm gonna just go closer, Line them up. Medial, tip. This is the pivot point. This is the guidance. Because I sometimes see when you start to do adjustment, right? Some doctor does this. It's completely going to the direction we don't want to aim, right? We aim for a specific disc angle. Okay, this is the angle I want to get. Line them up, then get the additional lift from this. Boom. 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 Medial epicondyle, medial rest, tip is going to be the line. Then this going to be the pivot point. Okay. Next one. Use your lats adductor to slack out, not the hands. Okay. This is something I realize for pelvic bench as well. Okay. It sounds weird, but when you do a pelvic bench, how many of you guys are using the adductor? It's weird thinking. Let's start to use the adductor. It's crazy, even push. Maybe I'm gonna just deviate, bear with me. Cervical chair, right? Okay. I don't know if we can do this. Marcus, can you make me as stop about the presentation?
Yes.
So I'm gonna be a main guy. Okay, perfect. Okay. This is my ASS angle. ASS angle. Did you get that? Thank you. Okay. Boom, right? Setting up right here, right? Then when you do adjustment, right? Your big toe needs to be there. Your big toe about the back side of the leg is there. Then when you adjust, everything comes together. Boom, right? Boom. I see sometimes some doctor is adjusting like this. Can you see? Knee is going out, right? Then when you adjust, your vector is gonna lose it. That's what we call hip, right? Sorry if you have a female doctor, but girl's hip, right? Like this. So vector is losing. Instead, when you are really focusing on the adductor, you almost like, any sport you do. Scott, you with me right now? You capturing me, right? When you are playing the baseball, right? When you are playing tennis, when you are playing ping pong, right? Watch. Nobody is losing the big toe, right? Nobody is losing about the disc. A little tiny pronated. Then your weight is on the football. I played football one day and I quit second day when I was in college. That's a true story. Okay. But like what I see is I want to see this mechanical. Then when you focus on the stabilization with your hand too much, hand gonna start to tensed up. You know what I'm saying? Hand gonna start to tensed up. Instead, use the older adductor. In your case, this is lats and pec to adduct. So your hands are so soft and nice and relaxed. So when things are come together, it's no longer anymore, but still nice and soft hand. Then what you need to do is boom, boom. Same thing, boom, 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 right there. Everything is lining up, vector match. Then when you are adducting, so sometimes I let my knee go a little bit more as well to come together. When you come together and stabilize, still hands are nice and relaxed, then only things you need to do is boom. I catch you, write it down. Okay, go back to the presentation for me. Sorry, I need to drink the espresso. Okay, keep your hands soft. Keep your hands soft. I want you to write it down. 1/10. 1/10. I've been training my doctors, young doctors. You gotta use the 1/10 of your fourth to set it up. 1/10 of fourth. 1/10. Not the 1/3, not 1/4, 1/10. Then you need to be that soft. You need to be that flexible to set the joint. Cool. Next one. Use your lats, rest, rest, rest. I talk about this. Dr. Gonstead said this. It's not the rapid punch, right? Punch gonna happen when you do this. Punch gonna happen for the tricep extension, right? Then I see this over and over when we see a certain Instagram video, right? If your elbow is traveling there, you are adjusting way too much and you are using the way more tricep. You know what I'm saying? I see sometimes this, right? Then do this, punchy. Boom. Can you see how much elbow is moving? Right? Do you want to move this much for the patient disc?
No.
Or you want to precisely move that disc like this size and precisely move this much? That is the more fine tuning. It almost like a laser cut precision doctor's work, right? Do you need a gross muscle to conduct that, or you need a fine motor skill to get that angle? Just boom, boom. Everything line up so perfect, so it's not gonna move anymore. The only things you need to do is the rest. Then if you forget about everything else, sorry, Dr. Sean, I'm trapping you off for the last 20 minutes and you are not even talking, so thank you, I appreciate you. Okay, I want you to see this, write it down next to this, rest. We are designed to provide an awesome adjustment. When you use the rest for any kind of adjustment, including cervical chair, including the extremity adjustment like a calcaneus, including about the knee chest, right? Any kind of adjustment, I want you to really keep your wrist flexible, then do fine tune. Knee chest, come on right here, knee chest, look the sky, come on right here. Right there, boom, lining up, lean, vector match. Only things you need to do is, when you do this, can you see that? It's arc, it's I2S, P2A automatically. Calcaneus adjustment. Okay, calcaneus adjustment. Some people are laying down right here, right? On the back, supine, calcaneus adjustment. Then we don't do a yanking adjustment. You do this, calcaneus. Boom. Boom. I'm going to say one more time. Oh, boom. Can you see that? So this gonna give you about the arc automatically. Let me show you about the wrist adjustment, right? I see wrist adjustment, like this. No, you're moving too much. If you set the joint right here and relax your shoulder, literally what you need is this much. Move. I don't know if it's the right things or not, but it moved. Sorry, I manipulated. I admit right now. But can you see this? This. Can you see that? When you do that, you can relax. Then also you create a decent amount of speed. Then also you can create about the I2S automatically and P2A automatically. So practice. Do it with me right now. I'm watching you. Can you see that? Right there? Right? Go like this. Practice in front of the camera. I'm watching you. Max, I don't see it. Mario, I don't see it. Right here. Practice. Rest. There we go. Nicola from Spain. I don't see you. Right? Then you need to do this, right? Then we sing a song together, right? Money. Give me. No, sorry. Not the money. Money. How it goes? Give me. Subluxation. Hoo. You gotta practice every single morning. Got it? Dr. Sham, you blessed to be in the Cornerstone Community Chiropractic. So blessed, he said. Okay, moving on. Okay, I want you to. Okay, why don't we watch the why don't you watch the video one more time?
Okay.
Oh, 3 o'clock. We gotta finish. How many more slides? Okay. Let's play quick. I just want to know.
Now, with this right hand, the female right here on the right side, I got right over his ear, and I'm really pressing his head into my sternum to stabilize.
We already watched that. Okay, moving on. Next one. We're almost done. Advance number 18. Nose. When you do a cervical axial adjustment, when we see the really good adjustment, right? You see this. Nose gonna go just a little bit, go up. Can you see that? If nose is going this way, is it a good adjustment? Everybody say no, right? If nose is tilted to this way, when I adjust it, it's a scissoring adjustment. So watch nose when you practice. We, Dr. Sean, me, Dr. Mikey, other doctor, start to record our adjustment on a regular basis, and we critique each other, right? Then when we critique, right? When you do an adjustment for right there, boom. Then when I do adjustment, the nose gonna go just a little bit go up, That is opening the disc, and that is setting the P2A and I2S, right? Watch the Dr. Gonstead video. His wrist is not moving. His elbow is not moving so much. Only thing patient nose go up like this, just a little bit. Okay, nose. Okay, move. Oh, this is a good one. Watch. I want you to play. And I'm gonna be almost done. 3 or 2. I don't know if we have audio or not. I don't know what just happened. Can you play one more time? There you go. Boom. You see that? The nose go just a little bit up. Boom. You see that? There is no twisting, no scissoring, just nose go up just a little bit. That is the good indicator. If your body moving, that means you are using the tricep too much. Okay, next one.
I have a question, Doc.
Yo, Edgar.
On this video, his contact elbow is quite lateral, no? I mean, I don't know
so.
what he's doing, but he's just
I don't
looking
know
at
what he's doing.
Yeah, exactly. But no, I was just wondering.
I cannot critique him. I'm not good enough to critique him. But my main point is this, right? When you do a good adjustment, nose gonna go up just a little bit.
Yeah,
cool.
yeah.
Okay. Demonstration. So this is a systematic way to go over one by one. Then I want you to see this. Okay. Perfect patient placement. Come on this way. Go back. Okay. For Dr. Sean, I want a vertical right there. Okay. Right there. So step number 1, write it down for me. Step number 1, flexion. So open up the spinous process. Then step number 2, tissue pull. Tissue pull I to S, either lateral to medial or medial to lateral. Then get the contact right on the spot. Write it down, straight finger, right? Yes. Then number 4, use your chest and use your 2 finger to bring it back to the neutral. Some people's neutral is right here. Some people's neutral is a little bit behind. So you need to play where the person's neutral spot is to open up the front side. Okay, then now you're gonna do a lateral bend from the segment, lateral bend from the segment, right? But I want you to, now he's falling down, so I gotta watch out for this one. Okay, based on what I know about his disc, he doesn't need that much about the chin up. So I just simply do this, okay? Then pinchy, pointy thumb, pinky down. So your elbow is more inferior than the wrist, and your wrist is more inferior than the tip of the finger, okay? From here, thinner, and spin, right there. And this is coming into the chest. This is going forward. Then it's not gonna go anywhere. Use the adductor to bring it in. Then last one, coming, bring in. By using the adductor, the only things you need to do is opposite side. Flex, tissue pull. This one, I2S and medial to lateral. Transverse contact. Straight finger, stair stepping. Use the chest and finger. Now I got it. And depending on where you want to see, do you want to create the more lordosis? Do you want to keep it really neutral? Right there, boom. Hook it, pinchy. Depending on where you want to get the more I2S or more P2A, I use the thumb location a little bit different way. Got it. I pinch it just a little bit, enough. Now, spin, femur coming in, then elbow tuck in, and match. Boom. Then come together, and boom. And boom. Boom. That line of correction needs to be determined by the wrist angle as well. Okay, Marcus, next one. Do you have a presentation? It's pretty much after the cases, yeah?
Yes, it said cases next.
Mm-hmm. Do you want to go over the cases? We're pretty much done for the time. I can go over a couple sample cases for you if you allow me to. No, it's not gonna. Oh, no, I think we can watch it. Do you want to see the couple cases to change it up, or it's about time?
For sure. I mean, everyone is, of course. That's great. Thank you.
Okay. So stay there. Because I just threw right there. Then Skype, I want you to capture this. Okay. With this. Can you guys see this X-ray?
Yes.
Okay, so lateral, you can see that. So this is totally kyphotic neck. Can you see that?
Mm.
Okay, then let's say I am adjusting the T2 PRI-T. Okay, T2 PRI-T. Okay, I know that I am not adjusting the kyphotic area. I know that, but Dr. O'Hare said this. If you wanna correct the segmental, you need to think about globally. What I mean by that is, let's say I'm correcting about the PRI-T, T2. or T3 or whatever case is, based on this, I mean, kyphotic area not gonna affect so much. But if I'm adjusting this patient, okay, this is not off berg. So Dr. Sean, come on right here. Okay, PRI-T, okay. Kyphotic neck, 7, 1, 2, okay. So the contact is all the way down, okay. Then visualize that spine, okay. Obviously, Dr. Sean's spine is not that, okay. But what I want you to see is this, okay. When I set it up, his jaw is way, way up there. Then hold it right here, okay. Yes. Yes. Instead of keep it tight, really neutral, and adjusting this. I bring it his nose a little bit more. So what I am doing is by seeing about the cervical and upper thoracic globally to see how this joint can opening up better. But obviously cervical chair might not be the primary table, right? When I see that, maybe you want to do a prone, but prone, same things as well, right? If I'm adjusting the prone for the T2, PRI-T, instead of setting right here, I'm gonna ask my patient to chin up a little bit more. Then now it's opening up way, way more. Then setting about the T2 PRI-T. Okay, can you see the difference? I'm gonna show you a couple more different cases. Okay, so I want you to see the X-ray. So he has a almost like a reverse cervical, but I want you to, Dr. Sky, go down to the thoracic area as well. Can you see, like, you know, pretty much thoracic to the cervical, there is no lordosis, no kyphosis, no nothing. So it's almost like, you know, straight spine going on up and down. Okay. Now I want you to see the AP. Okay, now watch this. Okay, now I'm addressing about the T2 PRS, but can you see the way, way bigger global curvature is going on the right side? Can you see that? Okay, so it's not just a simply PRS T2, but bigger convexity is going on. So let's visualize that one, okay? So come on this way, and if I'm adjusting this guy, T2 PRS, if I choose to the cervical chair, palms up for me, kick your feet all the way forward. Everything is straight, okay? Go like this. Big global curvature is going on. So I might be doing a little bit more lateral bend to the right side more than usual. So same concept right there, bring it back. There, I am going to probably do way, way more chin up. Now, as I chin up, I'm gonna kind of feeding in. Then also I do a little bit more lateral bend since I need to overcome about the global curvature. Right there. Obviously, I am not adjusting or manipulating the multiple segment, but by considering about these things. Okay, is this person, I need to do really chin up. Is this person, do a lateral flexion. I want to keep it minimum, but you know what? For this person has a way, way big global curvature is going on. So if I do a minimum lateral bend and keep it neutral, it's actually still straight. So I want to do a little bit. Okay. Another, you know, things. Can you see sometimes, you know, super straight spine, AP, there is no deviation. Even though it's a meniscus PRS, I might be doing this. If it's an AP, super straight, watch. But kyphotic neck, I just do this. Boom. And I just, boom. I just straight. Even though it's a minor PR or minor PRS, I just literally bring the nose all the way up to overcome the kyphosis. Then I just boom. This is kind of like, you know, advanced stuff. Maybe I shouldn't say that as a GMI instructor because we try to stick with as neutral as possible. Maybe a couple more and I'm gonna be done.
Doc, someone asked in the chat earlier that
Mhm.
would you ever change the cervical chair angle for something that's presenting the patient's spine or to get the doctor's chest even with the patient's head?
Great question. This is a perfect example for you. Okay. So when we see this guy, can you see that pretty decent lordosis is going on? Can you see that? So cervical, but when you go down to the thoracic, he has a more, bear with me, he's a big guy. It's more like, hyperkyphosis is going on. Okay. So in that case, I am probably changing about the angle of cervical chair. So come on this way, Dr. Sky. Okay, so presenting this, right? It almost like can happen for the older folks as well. Hyperkyphosis going on. We don't want to stack right here, so we create the beautiful lordosis in the what we call pseudo lordosis, right? So in that case, if you're finding about the, let's say T1 or C7 or whatever case is, but it's already going anterior. So in that case, I'm gonna bring him way backward. Then open the kyphotic area as much as possible. Okay. Then I am setting up like this. What I want to do is, since you can estimate about the open wedge on the posterior side, if you're dealing with the upper thoracic area, what I try to create is how can we get closer to close the wedge as much as possible before I even adjust, right? Then close the wedge as much as possible, as neutral as possible. Then at that point, adjust. I'm not doing a supine cervical, but this changing the angle gonna help you. Does that answer a little bit question? Maybe.
Yes, thank you.
Okay. I want to go maybe a couple more, maybe one more. Then we're gonna be done with it. This is Sarah. Okay, this is another example. Whoa, sorry. Can you see? So this is the really kyphotic, right? Obviously, when we have additional kyphosis going on, maybe table choice might be a little bit different as well. I want you to, Dr. Sky, show about the, let's say I'm adjusting about the C7, PLS. Can you guys see? Spinous process is L going on. Yeah, around there. Then maybe minor global curvature is going on the left side. Okay, so in that case, come on over. Again, this person might be leaning backward because she's here, right? So if I'm completely neutral cervical chair, she's sitting like this. Doesn't help. I try to bring it back, but it's already tipping to the anterior side. So what we need to do is, if I'm adjusting this way, change the angle, open, then strap as much as possible to open the hyperkyphotic area first. Then it's a PLS. I'm gonna go opposite way. Thank you very much. Boom. Then it's a PLS. Then global curvature is going on like this. So if I keep everything in the super minimum lateral bend, I'm gonna probably operate like this. That's it. Boom. But in her case, I'm gonna keep the neck, the jaw as closer to the neutral as possible. Then a little bit more lateral bend. Boom, 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 boom. And thank you. Give a big hand of applause to Dr. Sean and Dr. Sky. Thank you. I'm gonna bring myself back. Okay, that's it for the entire cervical chair. I hope you guys learned something good. It's so good to see some of the people I saw in Spain or Malaysia or so many other people. I appreciate you for hanging out with me. Marcus, how are we gonna finish it? We're gonna finish.
That's perfect. I
Fine.
mean, if anyone has any questions, they can write in the chat. But we want to definitely thank you, Dr. Aki, and
Thank
everyone
you.
there at Cornerstone for donating your time and helping us. Like you said, we have people from all over the world, and it's not easy times for them to be on here. So we appreciate
Mhm.
everyone coming on. And
Can
all
I
you
can
do-
I pitch you something?
Yes, sir.
Still 19 people. Oh, people are leaving. Oh, before you leave, you need to listen this. Okay. I give you this. This is the free advice for you. Okay. If you are interested, then take a video of your cervical chair with your friend or student. Maybe patient doesn't appreciate that, but maybe with your friends. Okay. I want you to take a video. Okay. Then I want you to really actually adjusting. Maybe I shouldn't encourage so much if we have an instructor right here. But if you want to get constructive feedback, I'm gonna give it to right now 18 people. Okay, take a video from right in front. So this view, right? Take a video, then send it to my Instagram. I give it a critique.
Thank you so much for that. That's
But
so helpful.
give it to me before January 1st. So grab somebody as a sacrifice for the Gonstead community. Set the joint and adjust. Take a video, then send it to me for the Instagram. I'm gonna give you the constructive feedback for you.
Nice.
Thank you so much, Dr. Aki. We really appreciate it.
Have an awesome rest of the day. Merry Christmas and Happy New Year.
You too.
Awesome.
Thank you,
Thank you,
everyone.
Dr. Aki. See you.
See ya.